right, okay, good. So we'll move on to the next section, which is our clinical studies and registries update. So our first update, let's see here, let's go to the agenda briefly and remind myself here, let's see, our first speaker today, in terms of registry, excuse me, is actually Milan Minkoff. There we go. Who's going to give us an update on LCH4. Milan, can I hand it over to you? Here we go. The slides are coming up. So lots of progress, I hope, I think, to report here. So take it away, Milan. So, hey, Milan, you're still muted, so we can't hear you.
So, can you hear me now?
Yes, perfect.
So, dear colleagues and friends, I'm delighted to give you a short update onto the ongoing LCH4 study. As you can realize from here, it is almost a decade since we started and opened the study in Austria. Next year will be a decade. No, moving to have problem. So at the moment we have now 23 countries. Greece just recently opened the trial, but we have data from 22 countries at the moment. Here on this slide, you can see the overall accrual, and we have more than 1,700 patients. You can see that over the years, the patient recruitment numbers increased, but the last 2 years have been impacted by the corona pandemics. On this slide, you can see the distribution of the patients according to the initial stratum. And you can see the patients included in group 1, the multi-system LCH patients, patients in group 2, those with multifocal disease or with CNS risk lesions. And there are some few patients included into the CNS disease lesions, and most of the patients are in the observational stratum 6, patients with single lesions who didn't require systemic treatment and have been observed. And in this stratum, we try to look about the natural history of the disease. They have some patients at the last analysis not yet assigned to a specific stratum. And on this right side, you can see the relative contributions of the different countries. Just to remind you, the stratum 1, group 1 patients, those with multi-system disease, we have 2x2 factorial randomized trial with 4 continuation arms, 2 long arms, and 2 short arms, and respectively plus minus 6 MP. Here, the overall recruitment status over the years, and you also can see that we were close to the calculated one, but once again impacted by the pandemics. And here you see the total recruitments from different countries and also the characteristics, but it is not surprised to see that the young kids, most of them having organ dysfunction, as it is characteristic for multi-system disease. Here, the numbers that matter, those are randomization numbers, and you can see that even with regard to randomization numbers, we are quite good, and we have been stable over the last 3 years despite decreasing total numbers of patient enrollment. This means that the randomization rates was high and was good. And on this slide, you see the distribution of the patients among the randomization arms. It's quite even. And here, once again, you can see the contributions by country. And in summary, the stratum 1, group 1, the most important one, or the multi-system disease, you can see that we have now stable randomization numbers over the last 3 years. And if we can keep them in another 2 to 3 years, we should reach the final sample size, particularly if you consider Canada just started to enroll patients, and so also Greece joined us. The next one is the stratum 1 group 2 patient with multifocal disease or with CNS lesions. And for this group of patients, we asked the question whether prolonging the continuation treatment would improve cure rates and prevent relapses. And we were quite good with the overall recruitments numbers. And here you can see the total numbers and their characteristics. We have multifocal bone disease, CNS risk, patients who have both of the lesions. But most importantly is that even the randomization were better than we expected. So over the last 3 years, we are above them. And here I can give you the good, exciting news that we have reached the target of 400 randomized patients. You see here the even distribution between the two arms, and here the contribution by country. So target reached. What is now? I think that to prevent the questions, are we going to stop now? I think that we need to now to perform the final data check, but particularly to see for completeness, eligibility. And you know that in such analysis, sometimes there are patients who drop out. Therefore, I think it is reasonable for the next couple of months until we have this checkup on data analysis and until we have the DSMC review to keep including patients and keep randomizing. I think if you randomize another 10 to 15 patients, it will be ethically okay, and we still can be sure that we have 400 evaluable patients. Stratum 2, it was the first attempt in history to give uniform second-line treatment for patients with non-risk disease. And here the randomized questions is regarding the continuation treatment to different regimens, because the main question here is, are we able to keep the patients in sustained remission or to cure them? And we have now, over the some years ago, have also to adapt design, because we wanted to have a phase 3 trial. We were concerned about the numbers we had, and therefore we changed the design to phase 2 trial. And this way we reduced the number of randomizations from 400 to 200. We have now all in all 150 recruited patients, enrolled patients. Here are the characteristics. But we have now about 74 randomizations. You see here the randomizations over the years, and we hope that we can keep them around 20 per year. And if you can keep this, we need another 1, maximum 2 years to close the stratum 2 either. You see here the distribution and the contributions by country. So, as already said, the study will take another 1 to 2 years, depending how the enrollment in the next year will be, how good it will be. And here you have also the, as already said, the change in the design. Stratum 3 is actually like a registry, no randomized questions, but when you design the protocol, you can recall that this stratum was included to evaluate the experience of the French group and also from the one salvage protocol. And the question here was more or less the early response to 1, respectively 2 cycles to CDRC. And of course, afterwards for the patients, there was a different kind of continuation treatment depending on response. For this reason, the French group has also prepared a statistical analysis. Therefore, we were aiming to include 30 patients. We have 18 patients. Here you see some of their characteristics, and it looks like it's feasible. We can reach the 30 patients, but if you compare with the numbers I showed you the last year, you'll realize that we have only 1 new patient recruited during the 2021. So I think that here there is an impact by the availability use of targeted treatments. It was quite understandable because we have to do the best for our patients. So therefore, I think we have to think within the study management group what action should be taken. All in all, the stratum 3 is like a registry. So even if we don't reach the numbers, we still can compare with the historical controls. And I think in the future, we'll need a kind of combined treatment, targeted therapy, and maybe other kind of therapy, which would allow for cure. In order to see whether this assumption is substantiated by the database, we looked at the database. We found out that there were almost 40 patients who have received inhibitors, vemurafenib, dabrafenib, totramitinib at some time of their disease course, and most of them coming from stratum 1, group 1. So we have to assume that most of them are among the patients who do not respond well, who have severe disease, and this really impacts on the stratum 3. But we didn't perform a detailed analysis of the data. The secondary strata, which are supposed to mostly recruit patients from the first line treatment strata, I can say that there are still no patients enrolled into the stem cell stratum 4. But maybe due to the new options, the transplant is now not that attractive. It could have a role also in combination with inhibitors or maybe with another kind of chemotherapy, putting the patients into good condition and then transplanting them. So here there are also possibilities to be explored in the future. In stratum 5, the neurodegeneration, which is the only stratum we can also come directly into the study, or come from stratum 1 or 2 or 3 at the moment patients are developing CNS disease. We allowed this in order to enroll more patients because CNS disease is quite rare, therefore we need numbers. And as you can see, during the last year, we have 7 new enrollments, 4 with the tumorous lesions and 3 with neurodegeneration. And in stratum 6, the observational stratum with single system, single site disease, we have almost 200 inclusions. So this is more or less about the recruitment numbers. I'm not allowed to disclose any of that. I'm not aware of them. They're usually discussed within the data safety monitoring committee. Regarding the severe adverse events, I can just briefly say there are no unexpected toxicity during the last year. And we looked also, are there deaths in this whole trial? And we found only 4 reported deaths, 1 due to pneumothorax, 1 in patients who has received the treatment of choice, was off protocol, received also vemurafenib and clofarabine after stratum 3 and died on progression of disease and sepsis. 1 patient died on sclerosing cholangitis, liver cirrhosis, progressive disease, and actually finally on sepsis, because the clinic couldn't provide the liver transplantation to those patients. And another one from the United States, the cause was cardiac arrest, but we don't have details what these patients actually had. Yeah, so this is, I hope I have to stop here because the time is also very limited. I would like to acknowledge the whole study management group. This means the national PIs, also the study statistician and Mrs. team for the study management, but also I think that the DSMC who volunteers also needs an applause, because they do all this job reviewing the data and helping us to make decisions. And of course, every country, every site are counting for this study, and Histiocyte Association had provided the money for the database. So thank you so much.
All right, excellent. All right, thank you, Milan. So I would say if there's any questions, let's put them in the chat because we have a tight timeline here. But that's a great update. Appreciate that. Okay, so next up is Stefan Ale is going to give us an update on the HLH registry.
Okay, let me share my screen.
Yes. And we hear you great.
Can you see it?
Yes.
Okay,
Great. It's perfect.
Thanks, Mike. Well, this is an update that was done in June by Svea Liedig and Katharina Wustbrau, and I didn't have really the occasion to update it, but it will give you a glimpse on where we are. So a brief note on the background. This is a quite slim registry, not going into details as the LCH is. And the primary goal of the registry was to collect data relevant for assessment of feasibility and design of future intervention trials. Because of difficulties in the past, actually, to recruit appropriate numbers of patients. So what we wanted to do is to analyze the target patient population that is treated by centers potentially participating in such studies, to provide data on overall outcome of contemporary standard of care rather than using historical data, improve the network of physicians collaborating on HLH, and implement routines for patient identification and central registration, and also to train the use of a GCP database that would be suitable for clinical trials. So this is a 5-year update. The inclusion criteria for the registry are patients receiving HLH-directed therapy and fulfilling more than 4 of 8 criteria, and also all genetic cases, even if they are asymptomatic. Exclusion criteria include malignancy, rheumatological, autoinflammatory, autoimmune disease, metabolic diseases, leishmaniosis. So the target group of this registry are really patients with what we call primary HLH as a first relatively clearly defined group. 178 patients have been recruited via the Marvin platform, 11 Swiss patients via the EASID registry platform, and 159 of these patients at the time of this analysis had a 1-year follow-up. So these are the registered patients, 88 from Germany, 10 from the US, 8 from Israel, and as you can see here, there was a contribution of 42 patients by Egypt, but some of these patients are actually retrospective and stem from the time period before 2016 when the registry was opened, and therefore we did not consider all of these patients in the analysis. These are additional recruiting countries and countries that are preparing participation to the registry. So the classification of HLH subtypes was asked again at the 1-year follow-up, and you can see that 124 patients were primary HLH, and there were some secondary HLH due to other reasons which unmasked after registration and could be assigned to secondary HLH. 39 of the primary HLH groups were from Egypt, as mentioned, mostly documented retrospectively, and we need some clarification here. Clinical presentation was usually with systemic HLH, but there were 6 patients with isolated CNS HLH, and there were also 14 patients identified asymptomatic by sibling screening. Disease-causing mutations were available for these 124 patients with some missing data and the usual expected distribution. Maybe it's worth to note that there was quite a significant proportion of patients with Chidiac-Higashi and Griscelli syndrome type 2 here in these parts of the graph. Disease trigger, as also expected data, you can see, and this may be noteworthy, that in 66% of the patient, no clear trigger could be identified, whereas in the others you see viruses as a most prominent trigger of disease. 14 patients had already received etoposide, 2 patients had received Campath before transfer to the reporting center. And I think this is also relevant for study design, because some of these patients are actually already treated when they come to potential study centers, meaning that it's difficult to include them into trials. 113 patients had reported treatment, and you can see that the distribution between etoposide, ATG, and Campath as main HLH remission-inducing drugs was mainly in favor of etoposide in these last 5 years. 66 of 85 patients with primary HLH, not counting Egypt, were transplanted, and 18 of 85 patients died. But here I'm not fully sure if all 85 patients have completed the 1-year follow-up. I need to discuss this with the team in Hamburg. Causes of death, primary treatment toxicity, infection, persistent HLH, and a group of patients where this could not be clearly distinguished. Some HSCT-related mortality, and other here, which is also probably in some cases after transplantation. Again, we have to look at the details here. This is the sequence of events until death in a group of 16 of these 18 patients. And it just gives you some idea that there are some, as we all know, that are very difficult to capture. They die early. These will also not be really recruitable into clinical trials. For most of the other patients, you can see the gray ones are those that were eventually transplanted. And most of the patients were transplanted early within the first 3 months, also of these patients that died during treatment. So although moving forward in the time point to transplant, there are still, of course, deaths occurring. We asked one question whether patients would, in retrospect, qualify for an interventional treatment study, and received the answer that around 24% of the patients would not qualify, either because disease was not severe enough, so the patients identified by sibling screening, the disease was too severe, the patient or family would not have consented, or there was severe CNS damage already at the time of initiating HLH-directed therapy. And I think this is relevant again when considering potential numbers for a trial. So no clear-cut results here, just some thoughts. We recruited around 25 patients per year with primary HLH in a worldwide effort. No more than 75% of such patients would qualify for a study. I think we have some signal that contemporary standard of care results are probably better than anticipated, including the etoposide results, but this will require further analysis. And I think a preliminary conclusion is that a randomized trial for the treatment of primary HLH with the goal to show better performance than standard of care will just not be feasible. And we have discussed this in the past. So with the attention that the registry currently gets and the difficulties in the different countries to enroll patients, I think these difficulties will also be difficulties of a trial. And I think the numbers needed for a randomized trial are just too hard to get. So how will we go on with this? I think we will continue with a more detailed analysis of the current data set in the remainder of the year. I think we also should discuss and consider whether we also open this effort to enroll retrospective patients of the last 5 years to get a better overview based on a larger data set on current treatment results. And overall, I think it has been a lot of effort also to raise funds, and we have to revise goals, protocol, and structure of the registry in the future to see, to really make sure that the effort is worth it. Thanks for your attention, and I would like to acknowledge all contributors to the registry, and I'm sorry I don't have a slide with all your names here. I was afraid of missing some. I would like to acknowledge the HLH Registry Steering Committee, the team in Freiburg who helped me, the team in Hamburg who is doing much of the work, the many countries that are contributing, and the funders, Histio UK, and several German funding agencies who helped us to perform this work. Thank you.
All right, great. Thank you, Stefan. All right, excellent. Okay, so again, if you have any questions, please put them in the chat and hopefully Stefan can get to those. So next up, we have a very brief update on the Rare Histio Disorders Registry from Osama Abla. So Osama, take it away.
Thank you, Michael, and hello, everybody. On behalf of the steering committee of the registry, I would like to give a brief update on the Rare Histiocyte Disorders Registry. Next slide. So far we have 18 sites open to the registry since April 2015. We have 143 patients enrolled as of October 5, but we have 54 pending, still pending central pathology review. The age range was between 2 months and 77 years. There were more males. We have 35 Rosa-Dorfman disease cases. 19 were confirmed by central pathology. 11 of these were nodal, 6 systemic, 2 extranodal. 14 are still pending path review. 2 were ineligible. Unfortunately, there are multiple data that are missing, so I cannot share more. We have 46 GXG cases. 13 of them were systemic, 20 cutaneous, 5 were adult GXG, 1 was progressive nodular histiocytosis, 1 benign cephalic, 2 intraocular, and 4 without defined subclassification. Next slide. We have 26 Erdheim-trusted disease cases. 18 were confirmed so far by pathology, 8 still pending. Most were refractory to first-line therapy, and many have had 2 or 3 or even 4th-line therapies. They were very responsive to BRAF and MEK inhibitors. We have 10 cases enrolled as malignant histiocytosis. 4 were confirmed and 6 are still pending path review. 4 were treated with intensive chemo, 2 had surgery, and 1 had radiation therapy. 3 patients of these are in CR, 1 has an unknown status. We have 4 cases with ALK-positive histiocytosis, only 2 were confirmed. We have also 18 other cases, 2 were confirmed by pathology, 1 was xanthogranuloma, and 1 was indeterminate cell histiocytosis. And 16 are pending. The data on the treatment and response and outcomes are missing in many cases, so I cannot share more data, unfortunately, at the moment. Next slide. So this is the cutoff, cut down of all the centers and the cases. We have 2 centers from Canada, 6 from the US. Memorial Sloan Kettering with Eli Diamond continues to be the largest contributor. 1 center from Argentina and 9 centers from Europe. Recently, the Netherlands and Germany and Italy started contributing patients. Thank you so much for all the collaborators. Next slide. So next step, we would like to complete the central path review of all the remaining cases, obtain follow-up data on outcomes and treatment. We're going to do some cleanup of the data with our CRA, and would like to submit an abstract for next year's meeting. And also my other goal is to get an amendment with our IRB and try to get genome sequencing of all the patients so that we have treatment, clinical, and even biological data on all the patients. Next slide. Finally, I would like to thank Jim Whitlock, my co-PI, Sheila Weissman, and Ken McLean, who gave me the idea of the registry, and all the collaborators, and especially Jennifer Pekarsik. She reviewed most of the cases in pathology, and the Histiocytosis Association for their support, and mainly patients and their families. Thank you so much.
All right, great, excellent. All right, thank you, Osama, and thank you all the presenters for updating us on the society efforts in these different diseases.